Thank you so much for the invitation to speak today and to talk a bit about sex differences in thrombosis. And so just to remind everybody, on average, women present about 10 years later from their first myocardial infarction than men do. And several of the risk factors, particularly diabetes and smoking, have much more of an effect on women in terms of myocardial infarction than men. In fact, diabetes eliminates the age gap between men and women who smoke are about twice as likely as men who smoke to suffer a myocardial infarction. So why is this? Well, certainly women have smaller epicardial coronary arteries and have increased blood flow, and that may affect shear along the endothelium. That may result in this more diffuse coronary artery disease pattern that we see, and the fact that women are more likely to develop plaque erosion than rupture. What are some of the underlying sort of biochemical differences between men and women? Well, certainly the presence of estrogen and estrogen receptor alpha in particular in women seems to play a role. There are reports that iron metabolism could contribute to these sex differences. We know that pregnancy, particularly pregnancy complications, either may be a marker or may itself have long-term sequelae in terms of vascular disease in women. Women seem to be more prone to mental stress and psychosocial factors than men, and certainly socioeconomic and epigenetic modifications may be contributing to these sex differences. I'll remind everybody that estrogens and testosterones have very different effects on some of this underlying biology, both in terms of risk factors like lipoprotein metabolism, but also things like coagulation factors and platelet function. That may result in differences in how women and men present with myocardial infarction. What about treatments in women and men? Well, certainly in terms of PCI versus lytic, if you look at benefit, about 56 deaths are prevented per 1,000 women versus 42 deaths per 1,000 men. And so women gain more benefit from PCI than men do. And if we look at antithrombotic therapy, there are really fascinating differences, particularly in the effects of aspirin. And so we learned from the Women's Health Initiative, which randomized women to placebo or relatively low dose aspirin, that aspirin reduced the risk of stroke. Again, primary prevention, use of aspirin, reduced the risk of stroke in women. Whereas in studies of men, for primary prevention, aspirin appears to reduce the risk of first myocardial infarction. And in fact, if you look at pooled studies of either men or women, what we see is a very consistent effect of aspirin reducing myocardial infarction in men and reducing stroke in women. Well, why is this? We know that there are differences in how platelets respond, both in women and men, and the effects of aspirin in women and men seem to be different. This is probably the largest study to look at this, just shy of 1,000 total subjects, women in the open bars, men in the dark bars, looking at a number of different platelet activators and the effects in terms of platelet function before and after aspirin. And you can see across the board that there are statistically significant differences in how women and men respond both to the platelet activator, but also to the effect of aspirin. And so in addition, platelet counts are higher in women. We know that estrogens have effects on platelet inhibitors like prostacyclins and nitric oxide, and that there may be direct effects of estrogen. There's estrogen receptor on platelets, and this may directly affect how platelets are functioning. So what about other antiplatelet drugs? So there's been a meta-analysis of the large clopidogrel trials. This includes CURE, Clarity, Commit, Charisma. And in this meta-analysis, there was benefit in terms of risk of major adverse events of clopidogrel in both women and men. And so the odds ratio in women was 0.93. The odds ratio in men was 0.84. The difference between men and women was not statistically significant, with a p-value at 0.092. Similarly, for ticagrelor, meta-analysis of the effects of ticagrelor versus placebo, there is a risk reduction in terms of major adverse cardiovascular events in both men and women, and the impact seems to be fairly similar. And so it does not appear that for either clopidogrel or ticagrelor, there are major sex effects in terms of reduction of major cardiovascular events. I'd be remiss if I didn't touch briefly on bleeding in women. We know that rates are higher, especially after PCI historically. This has been attributed to the older age of women at time of presentation, their lower BMI that may result in lack of dose adjustment of medications, and then other biologic factors that may predispose to bleeding in women. I will point out, though, that in a very contemporary analysis of bleeding, particularly high-risk individuals with bleeding, this was a study in which patients were randomized to bare metal versus drug-eluting stent. There were actually no differences in BARC major bleeding between the sexes, looking out at an extended period of time. I will say that at 30 days, women did experience more major bleeds, but over an extended time, there really was no difference in major bleeding between the sexes. There are also no differences in ischemic outcomes, but I will remind everybody that bleeders versus non-bleeders have more ischemic outcomes. And then just briefly to touch on atrial fibrillation and risk of stroke in women and thromboembolic events. Women are at higher risk of a thromboembolic event if they're not managed with an oral anticoagulant than men are. So atrial fibrillation carries a higher risk of thromboembolism in women. Women respond to the direct-acting oral anticoagulants with a larger risk reduction than do men. So they start at a higher risk, but they gain more benefit from the direct-acting oral anticoagulants. And so despite this, if you look at use of the oral anticoagulants in women with atrial fibrillation, regardless of underlying CHADS VASC score, women are across the board less likely to be treated with an oral anticoagulant than are men. So women here in red, men and women across the different CHADS VASC scores. And so I think it's incumbent upon all of us to remember when we're seeing women with atrial fibrillation to really consider the use of oral anticoagulants in this patient population. And so just to remind everybody in sort of conclusion, thrombosis is a very common cause of both death and disability, and there are clear underlying sex differences. Very much appreciate this opportunity to speak with the group, and looking forward to all of the rest of the presentations at the